What's the real ideal blood pressure after 65? The answer will surprise you. For countless individuals navigating the intricate landscape of healthcare after reaching the age of 65, the familiar ritual in a doctor's office often unfolds with a deeply ingrained, almost universal message about blood pressure. As the dedicated nurse diligently notes down the latest reading, patients frequently encounter a variation of the same directive, a seemingly straightforward command that carries significant weight. That number needs to come down, or we want to get you below 130/80, or perhaps the gentler but equally firm pronouncement, your pressure is a little high, and we should talk about medication. For the vast majority of seniors I've had the privilege to speak with, this advice, delivered by trusted medical professionals, is accepted not just without question, but with an inherent and profound faith in the medical system, a belief that these targets are unequivocally in their absolute best interest. Consequently, many return home, often embarking on a new pharmaceutical regimen, perhaps a new pill added to an already complex daily routine, or redoubling their efforts to restrict dietary salt with even greater vigilance, increasing physical activity to strenuous levels, and carrying the pervasive burden of added worry, all driven by the seemingly incontrovertible message echoing in their minds. Lower blood pressure is undeniably better. Get that number down, full stop. This pervasive narrative, however, presents a profoundly simplified and, for a significant demographic of adults over 65, an actively misleading and potentially detrimental picture. What remains largely uncommunicated during these often brief routine appointments is that this framing, the notion that lower is always superior, is not merely incomplete. It can, in fact, be directly counterproductive or even actively harmful for a meaningful percentage of older individuals. The robust scientific body of evidence supporting a far more intricate and nuanced understanding of blood pressure management in older adults has been steadily accumulating for years, meticulously published within the most respected cardiology journals and geriatric medicine literature. Yet, alarmingly, millions of seniors continue to receive care guided by targets and clinical guidelines that were never specifically conceived, designed, or validated with their unique physiological characteristics, age-related changes, and inherent vulnerabilities in mind. This constitutes a profound disservice as it neglects to equip older patients with the full spectrum of information necessary for truly informed decision-making about their own health. I am Dr. Elena Pierce, and through this channel, my unwavering commitment is to empower adults over the age of 60 with evidence-based health information that the severe time constraints of a typical 15-minute medical appointment rarely permit time to explore in sufficient depth. Subscribing now can genuinely revolutionize your comprehension of your own blood pressure readings and fundamentally reshape the crucial dialogue you engage in with your healthcare provider during your subsequent visit, transforming it from a passive reception of instructions into an active partnership built on knowledge and shared understanding. Let us commence our exploration by deconstructing the number itself, for there exists a profound and widespread confusion surrounding the actual meaning and precise clinical implications of blood pressure readings. This lack of clarity is exacting a heavy and often silent toll on the health of seniors in ways that paradoxically impact well-being in both directions, introducing risks associated with excessively high pressures, but also, critically, risks introduced by pressures that are pushed too low. A blood pressure reading is composed of two distinct yet intimately interconnected measurements, each reflecting a different phase of the heart's tireless work. The upper figure, universally known as systolic pressure, quantifies the immense and dynamic force that your heart exerts when it powerfully contracts, forcefully propelling oxygen-rich blood outward into the body's vast and intricate arterial network. This represents the peak pressure experienced within the arteries during the heart's active pumping phase, the moment of maximal exertion. Conversely, the lower figure, referred to as diastolic pressure, gauges the residual pressure sustained within your arteries during the vital period between heartbeats, specifically when your heart muscle is in a state of relaxation and actively refilling with blood. This reflects the minimum pressure maintained within the arteries as the heart rests, a crucial period for its own nourishment. For many decades, spanning the mid-20th century, the primary clinical emphasis within general medical practice was predominantly directed towards diastolic pressure. Medical textbooks from the 1970s and 1980s consistently highlighted an elevated bottom number as the paramount indicator of impending cardiovascular risk, forming the cornerstone of hypertension diagnosis and treatment. However, as scientific inquiry progressed, research methodologies refined, and larger population studies yielded new insights, this focus underwent a significant reorientation. By the 1990s and 2000s, systolic pressure, that crucial top number, had unequivocally emerged as the more compelling and accurate predictor of cardiovascular risk, particularly for adults exceeding the age of 50. This shift in understanding was pivotal. It is at this juncture that a specific and immensely significant condition for seniors, known as isolated systolic hypertension, enters the critical discussion with profound implications. Isolated systolic hypertension is characterized by an elevated top number, typically registering above 140 millimeters of mercury, while the bottom number, or diastolic pressure, concurrently remains within a normal, acceptable range, often below 90. This particular pattern of blood pressure becomes progressively more prevalent with advancing age, a direct consequence of a distinct and natural physiological process inherent to human aging. As the human body ages, the intricate and once pliant walls of its large arteries undergo a gradual but inexorable transformation. They stiffen, progressively losing their inherent flexibility and natural elasticity, much like an old rubber hose that has become rigid and unyielding. In stark contrast, younger, healthier arteries function much like supple, elastic tubes, capable of dynamically absorbing the forceful impact of each heartbeat and thereby ensuring a smooth, consistent flow of blood throughout the circulatory system. Older, stiffer arteries, however, are considerably less effective at absorbing this contractile force from the heart's powerful pump. This diminished ability to cushion the pulse wave directly contributes to the elevation of systolic pressure, as the blood has nowhere to give within the rigid arterial walls. This phenomenon of arterial stiffening constitutes a natural, intrinsic, biological process of aging, a wear and tear over decades. It is fundamentally distinct from the form of hypertension that often signifies chronic cardiovascular damage observed in younger adults, where both systolic and diastolic pressures are typically elevated due to systemic vascular resistance and dysfunctional endothelium. Crucially, approaching the treatment of this age-related isolated systolic hypertension with the same aggressive targets and pharmacological strategies employed for a robust 45-year-old individual introduces a unique and significant array of risks, specifically tailored to the nuances of older physiology and its reduced compensatory capacities. These are profound and often insidious risks that, regrettably, are almost universally omitted from standard brief blood pressure consultations, leaving seniors vulnerable to adverse outcomes. Allow me to elucidate the profound insights derived from the single, most pivotal clinical study concerning blood pressure targets in older adults, as it irrevocably reshaped the approach taken by truly thoughtful cardiologists and geriatricians. And yet, its nuances almost never permeate the confines of a routine primary care appointment. This landmark investigation was the SPRINT trial, the Systolic Blood Pressure Intervention Trial. This federally funded study was meticulously designed and executed, enrolling an impressive cohort of over 9,000 adults who were already categorized as being at elevated cardiovascular risk. The trial's core objective was to meticulously compare the outcomes associated with two distinct blood pressure targets, pushing the boundaries of conventional wisdom. One segment of participants was managed to a conventional target, aiming for a systolic pressure consistently below 140 millimeters of mercury. The other, an intensive treatment group, was vigorously managed to achieve a more aggressive target of systolic pressure below 120 millimeters of mercury. The immediate headline-grabbing result was undeniably dramatic and seemingly conclusive. The intensive treatment group exhibited a significantly reduced incidence of major cardiovascular events, encompassing debilitating heart attacks, life-threatening heart failure, and devastating strokes. This finding was so compelling, in fact, that the trial was halted prematurely. As continuing, it was deemed unethical, given the clear and undeniable benefits observed in the intensive arm. Within a mere few months, both the prestigious American College of Cardiology and the American Heart Association swiftly updated their clinical guidelines, advocating for target blood pressures to be pushed below 130/80 for the majority of adult patients. This updated guideline is precisely the one that currently dictates and drives millions of prescription decisions worldwide, influencing countless medical practices. However, and this is the profoundly critical aspect that the initial headlines entirely overlooked, and which your physician may never have fully elucidated or discussed with you in detail. In the very same SPRINT trial, the intensive treatment group also experienced significantly higher rates of serious adverse events. The incidence of acute kidney injury, for example, was a staggering 50% more common in the intensively treated group, a condition that can lead to permanent kidney damage or the need for dialysis. Dangerous electrolyte abnormalities, particularly critically low levels of sodium, hyponatremia, and potassium, hypokalemia, which can cause confusion, muscle weakness, heart rhythm disturbances, and even seizures, were markedly elevated. Furthermore, falls serious enough to necessitate medical attention were more frequent, increasing the risk of fractures and long-term disability, and syncope, the sudden, transient loss of consciousness, occurred with greater regularity, often leading to falls. A particularly salient finding within the SPRINT trial involved the subgroup of participants who were older and inherently more physically vulnerable, often described as frail. In this specific cohort, the delicate trade-off between the observed cardiovascular benefits and these profound serious harms became far less favorable, tilting precariously towards increased net risk rather than benefit. The researchers themselves, along with numerous subsequent independent commentators and careful analyses, explicitly noted and cautioned that the SPRINT results should not be indiscriminately applied across all patient populations. They emphasized, with no ambiguity, that for older, frailer adults, the individualized calculation of risks versus benefits is fundamentally distinct and far more complex than that of younger, healthier participants. Despite these explicit caveats and crucial nuances, the simplified overarching guideline, get below 130/80, regrettably permeated the medical community and rapidly became the default, almost dogmatic message conveyed to millions of seniors, irrespective of their unique physiological circumstances, overall health status, or inherent vulnerabilities. This widespread simplification inadvertently fostered a management paradigm that often failed to account for the very individuals most susceptible to the adverse effects of aggressive treatment, ironically, putting them at greater risk in the pursuit of an ideal number. Let me now delve into a critical physiological phenomenon, often unrecognized by the general public and yet profoundly impactful, which explains precisely why driving blood pressure too low in older adults can precipitate a distinct and often perilous category of danger. This phenomenon is termed the J-curve. When researchers meticulously plot the intricate relationship between various blood pressure levels and cardiovascular outcomes across vast epidemiological populations, the resulting graphical representation does not depict a straightforward linear progression where consistently lower blood pressure invariably equates to superior health outcomes. Instead, the relationship strikingly resembles the distinct shape of the letter J. As blood pressure progressively rises beyond healthy thresholds, the associated risk of cardiovascular events, quite predictably and intuitively, escalates in tandem. This segment of the curve, representing the dangers of high blood pressure, is widely understood by most individuals and forms the basis of much of our current hypertension management. However, it is the lower end of this curve that holds the profound and often overlooked clinical significance. As blood pressure descends below a certain critical threshold, the risk of adverse outcomes paradoxically begins to rise once more. This suggests the undeniable existence of a physiological floor, a point below which further reductions in blood pressure cease to confer benefit, and instead initiate a cascade of harm, putting the patient at increased danger. The most clinically profound manifestation of the J-curve phenomenon in the senior population predominantly involves diastolic pressure, that crucial bottom number. Multiple extensive, meticulously conducted studies analyzing data from thousands of older patients have consistently demonstrated that diastolic pressures falling below approximately 60 to 65 mm of mercury are intricately linked with an augmented risk of cardiovascular events, a concerning acceleration of cognitive decline, often manifesting as memory problems or difficulty concentrating, and tangible organ damage in older adults. The physiological rationale underpinning this increased risk is compelling and deeply rooted in the mechanics of the heart. During the critical period between heartbeats, when the heart muscle is in its essential resting phase and diastolic pressure is being maintained, the coronary arteries, those vital, intricate blood vessels responsible for nourishing the heart muscle itself, perform the vast majority of their crucial filling. This quiescent period is when the heart muscle receives its life-sustaining oxygen and nutrients. If the diastolic pressure precipitously drops too low, the heart muscle receives an inadequate and compromised blood supply during this absolutely critical resting phase. Imagine a garden hose that delivers water intermittently. If the pressure drops too low during the off cycles, the plants won't get enough water. In an older adult whose coronary arteries may already possess some degree of narrowing or atherosclerotic compromise due to decades of wear and tear or underlying disease, a diastolic pressure of, say, 58 is not merely an innocuous number displayed on a blood pressure cuff. It can represent a genuine state of silent ischemia, an insufficient delivery of oxygen to the delicate heart tissue, occurring insidiously, with every single heartbeat, without conscious awareness or pain. Over time, this chronic, low-grade oxygen deprivation can lead to cardiac damage and dysfunction. A seminal analysis published in the esteemed Journal of the American College of Cardiology unequivocally identified a clear J-curve relationship in elderly hypertensive patients, demonstrating a significantly elevated risk of adverse outcomes, including heart attack and stroke, at diastolic pressures below 60. Yet, in the majority of conventional clinical settings, the standard dialogue surrounding blood pressure targets remains almost exclusively focused on the top number and, regrettably, says virtually nothing about the potential dangers of pushing the bottom number too low. This glaring oversight leaves a critical and potentially dangerous gap in patient education and comprehensive management for our seniors. Now, let us turn our attention to orthostatic hypotension, a pervasive and deeply impactful blood pressure issue that directly jeopardizes the independence, mobility, and fundamental physical safety of seniors, yet remains profoundly under-recognized and tragically inadequately addressed in routine medical care. Orthostatic hypotension is defined as a clinically significant and precipitous drop in blood pressure, typically a fall of 20 mmHg or more in systolic pressure, or 10 mmHg or more in diastolic pressure, that occurs almost immediately upon transitioning from a sitting or lying position to an upright standing posture. In practical, everyday terms, this is the very physiological phenomenon responsible for that fleeting sensation of dizziness, lightheadedness, vertigo, or pronounced unsteadiness that many individuals experience when they rise rapidly from a chair, bed, or even a deep crouch. It's that momentary disorienting feeling as if the entire world has suddenly tilted sideways or blurred before your body's intricate circulatory system can adequately compensate and catch up. to the abrupt change in gravitational pull, sending enough blood to your brain. For a healthy 35-year-old, this fleeting sensation typically lasts a mere 2 seconds, perhaps prompting a brief grab for support, and is immediately forgotten, posing no real threat to their physical integrity. However, for a 72-year-old, that identical physiological phenomenon represents a critical potential fracture waiting to happen, a precursor to potentially devastating consequences that can alter the trajectory of their life. Extensive research consistently demonstrates that orthostatic hypotension becomes both significantly more common and considerably more pronounced with advancing age, a multifactorial phenomenon driven by several key physiological changes that reduce the body's ability to maintain stable blood pressure upon standing. These include a reduced sensitivity of baroreceptors, specialized sensors in the arteries that detect blood pressure changes and trigger compensatory responses, a slower and less efficient circulatory compensation mechanism, the blood vessels and heart respond more sluggishly, and a reduction in overall circulating blood volume. Critically, many commonly prescribed blood pressure medications designed to lower resting blood pressure can inadvertently exacerbate orthostatic hypotension, rendering the positional drop in pressure larger and more sustained, transforming a minor imbalance into a major fall risk. The consequences of such medication-driven events are far from minor or easily dismissed. Hip fractures in adults over the age of 70 carry an alarmingly high 1-year mortality rate, often approaching 30%, not just from the injury itself, but from the cascade of complications that follow, including pneumonia, blood, clots, and general decline. A fall directly attributable to blood pressure medication is therefore not a mere side effect to be endured. It represents a potentially catastrophic initiating event in a cascade that can culminate in the irreversible loss of independence, requiring long-term care, entry into assisted living, or leading to a significantly reduced quality of life and profound emotional distress. Despite this profound, well-documented risk to senior health and autonomy, when blood pressure targets are established and medications are carefully titrated, the orthostatic behavior of blood pressure, what it does when the patient actively stands up and moves, not just when they are quietly seated and relaxed in the examination room, is tragically and systematically evaluated far too infrequently. This glaring omission leaves a significant and unacceptable vulnerability in the comprehensive assessment and ongoing management of older patients, exposing them to preventable harm. So, amidst this complex tapestry of physiological nuances, age-related changes, and potential pharmacological pitfalls, what constitutes the truly right blood pressure target for older adults? This question lies at the absolute heart of the matter, and it demands an unequivocally honest, comprehensive, and patient-centered answer, one that transcends the alluring simplicity of universal directives. The candid truth, supported by the most rigorous contemporary medical evidence, is that there is no single, universally ideal blood pressure number that applies uniformly and safely to all adults over the age of 65. The optimal target is, by its very nature, highly individualized, contingent upon a rich constellation of unique factors specific to each patient, reflecting their personal health, journey, and current physiological state. These crucial individual factors include chronological age, with older age often necessitating a more conservative approach, the definitive presence or absence of established cardiovascular disease, such as a history of heart attack, stroke, or peripheral artery disease, the functional status of their kidneys, as impaired kidney function can influence both blood pressure and medication metabolism, their current cognitive status, as aggressive lowering can exacerbate brain fog, their assessed risk of falls, a critical safety concern, their overall level of frailty, a composite measure of physiological reserve and vulnerability to stressors. And critically, the specific medications currently being utilized to achieve any given blood pressure target, as drug interactions or side effects can complicate management. What the most current and robust evidence unequivocally supports, however, is a stratified, nuanced, and personalized approach to blood pressure management in older adults. For adults generally between the ages of 65 and 75 who maintain good functional status, are physically active, and exhibit no significant signs of frailty, a systolic target typically within the range of 130 to 140 millimeters of mercury is broadly supported by contemporary research. This recommendation comes with the crucial caveat that the benefits derived from more intensive blood pressure control must always be meticulously and openly weighed against the individual patient's specific risk profile, especially concerning the potential for adverse events like kidney injury or falls. For adults surpassing the chronological age of 75, and particularly for those who are demonstrably frail, manage multiple complex medical conditions such as diabetes, heart failure, or chronic lung disease, or face an elevated risk of falls due to gait instability or prior incidents, a more conservative systolic target ranging from 140 to 150 millimeter of mercury is increasingly advocated and strongly supported by leading geriatric medicine specialists as the most appropriate and individualized goal. This differentiated approach is not an act of permissiveness, nor does it imply a lax attitude towards essential health management. On the contrary, it represents a commitment to precision medicine, a profound acknowledgement that older bodies respond differently to therapeutic interventions and inherently possess reduced physiological reserves. It mandates tailored strategies that prioritize safety, maintain cognitive function, preserve physical independence, and enhance overall quality of life, alongside achieving cardiovascular protection. Armed with this deeper and more comprehensive understanding of blood pressure dynamics in older adults, here are the precise, actionable steps you can and absolutely should undertake before your very next medical appointment to ensure your blood pressure management is truly aligned with your individual needs and promotes your overall well-being. Firstly, and crucially, make it your unequivocal priority to ascertain what your diastolic pressure has consistently been. Engage your doctor in a specific and direct conversation, asking explicitly about the average of your bottom number over recent months and whether it has regularly registered below 70 millimeters of mercury. If your diastolic pressure is consistently below 65, this necessitates an explicit, thorough, and immediate discussion with your physician, not merely a casual reassurance. Such a low reading could signify risks of myocardial ischemia or other organ damage that demand immediate attention and a potential adjustment to your medication regimen. Secondly, invest in a clinically validated upper arm blood pressure monitor for home use. These devices are readily available and provide far more accurate and representative readings than wrist or finger cuffs. Commit to taking readings twice daily for a consistent period of 2 weeks, ensuring these measurements are taken at the same time each day, e.g., morning and evening, to establish a consistent and reliable baseline. Before each measurement, sit quietly and calmly for 5 minutes, allowing your body to rest and stabilize. Take 2 readings, separated by a minute or two, and meticulously record their average. Bring this comprehensive log of home readings to your appointment. It provides invaluable real-world data that complements single-office measurements, which can be affected by white coat hypertension. Thirdly, directly inquire of your doctor what specific blood pressure target is being used for your care, and critically, why that particular target has been chosen for you. Explicitly ask whether this target fully accounts for your chronological age, your individual risk of falls, your cognitive function, and the current functional status of your kidneys. You are absolutely entitled to this specific, individualized explanation, and it is a cornerstone of informed consent and shared decision-making, allowing you to be an active participant in your health journey. Fourthly, if you experience any sensation of dizziness, lightheadedness, vertigo, or pronounced unsteadiness when transitioning from a sitting position to standing or from lying down to standing, report this phenomenon to your doctor explicitly and without hesitation. Do not minimize it. Use the precise medical term, orthostatic hypotension. Crucially, request a standing blood pressure test, where your blood pressure is measured first while seated and then again within 2 minutes of standing, and possibly even at 5 minutes. This simple, yet often overlooked, diagnostic test can unequivocally reveal a dangerous medication-driven drop in blood pressure that would otherwise remain entirely undetected during a standard seated office measurement, potentially preventing a serious fall and its catastrophic consequences. Fifthly, if you are over the age of 75, currently being managed to a systolic target below 130 millimeters of mercury, and experiencing persistent, unexplained fatigue, a pervasive brain fog, difficulty concentrating or memory lapses, or frequent episodes of dizziness, do not hesitate to ask whether the intensity of your current blood pressure management could be a contributing factor to these debilitating symptoms. This is not an unfounded complaint or an attempt to avoid medication. It is a medically legitimate question, powerfully supported by the most current geriatric research, and it warrants a thorough and open reassessment of your treatment regimen, considering the potential for overtreatment. Consider the compelling and illustrative case of Margaret, who at 78 years old found herself in a precarious situation when her cardiologist, adhering strictly to the then prevalent generalized guidelines, adjusted her systolic target to below 130. For many years prior, Margaret had maintained a stable and perfectly healthy blood pressure, consistently hovering around 142, allowing her to lead an active and independent life. Within a mere 6 weeks of this intensified management, Margaret suffered 2 alarming falls, both requiring medical attention, and leaving her shaken and fearful. Her diligent home blood pressure readings revealed a troubling and consistent pattern. Her diastolic pressure was consistently sitting at a dangerously low 58 milliliter of mercury. Furthermore, her standing blood pressure plummeted by over 25 points within a startling 90 seconds of her rising from bed, a clear and undeniable indication of severe orthostatic hypotension. Fortunately, her insightful doctor recognized the gravity of these findings and judiciously stepped back her blood pressure medication, adjusting the dosage to a more appropriate level for her age and physiological profile. The results were swift and dramatically positive. Her debilitating dizziness resolved entirely. The pervasive brain fog lifted, and within 3 short weeks, Margaret had confidently resumed her beloved daily walks, gardening, and social activities, effectively regaining her cherished independence, vitality, and peace of mind. Crucially, her long-term cardiovascular risk profile barely registered a change from this intelligent adjustment, yet her immediate safety, physical comfort, and overall quality of life were utterly transformed for the better. This powerful anecdote underscores a fundamental and critical truth that all seniors and their healthcare providers must grasp. Managing blood pressure effectively in individuals over 65 is not merely about rigidly chasing a singular, often arbitrary number dictated by generalized guidelines. It is profoundly about deeply understanding and meticulously respecting what your individual physiology genuinely needs, recognizing its unique vulnerabilities, age-related adaptive capacities, and potential for adverse reactions to aggressive treatment. The overwhelming body of current research champions nuance, individualized assessment, and a truly patient-centered approach. You, as a senior, deserve nothing less than this informed, personalized, and respectful care. I invite you to engage with this vital discussion by commenting below with one of 3 responses. You can comment "my numbers" to share your own blood pressure readings and any insights you've gained. Comment "getting clarity" if you are inspired to bring these crucial questions and this new understanding to your very next medical appointment, ready to advocate for yourself. Or if you suspect your current blood pressure management might be negatively impacting your energy levels, balance, cognitive function, or overall daily function, comment "overtreated." I am personally committed to reading every single comment, valuing your experiences and perspectives as they enrich this collective understanding. Please take this critical information and share it widely with anyone over the age of 65 who is currently managing their blood pressure and has never had this profound, empowering, and life-changing conversation. I'm Dr. Elena Pierce. Subscribe now for more vital health insights that empower you to take control of your well-being. Next week, I will be delving into the specific blood test results that can predict kidney damage from blood pressure medications years before any noticeable symptoms even begin to manifest, providing another layer of crucial preventative knowledge. Until then, please take exceptional care of yourself and advocate for your unique health needs.